So I think we'll start. We'll do about 20 to 30 minutes of a quick talk. We have 3 topics to quickly look at. And today, I promise not to make it too medical, so that we make it as simple as possible, so that we pick the salient points and we can ask questions from there or from any other questions we have in mind. Today we'll be talking about miscarriages. And let's before I forget, we can always go through the old antenatal classes which are recorded and can be found online. There is a Zoom link. You can always follow up the Zoom link and listen to any of such classes. And if you do have questions from any of those classes, you can jot your points down. And when we do see in the antenatal clinic, you can quickly ask 1 or 2 of those questions and clear your doubts. Today we'll be looking at 3 topics. 1, miscarriages. 2, cerclage, what we call a cervical cerclage. And 3, placenta previa. So very quickly we'll touch on miscarriages. What is a miscarriage? Another word for the miscarriage is an abortion, but abortion, when it's being used in the clinic setting, looks a little bit more like a woman went to terminate a pregnancy. So we'll stick with the word miscarriage, which looks less offensive to the woman. Okay, but those words could actually be used interchangeably in obstetric and gynecological practice. So miscarriage, what is a miscarriage? As we all know, that is the expulsion of the products of conception, either the fetus, the embryo, before the age at which the baby can live outside of the womb, which we call the age of viability. Okay, that is losing the baby, expelling a baby before the baby gets to the age of viability. And the age of viability differs across the world. For us here in Africa and Nigeria, our age of viability is what? 28 weeks. That is about 7 months, right? But that is not so in other parts of the world. In the UK, the age of viability is 4 weeks lesser than ours, 24 weeks. While in the US, it's about 20 weeks. While the World Health Organization looks at the age of viability at about 22 weeks. You can see a far cry from our 28 weeks. Okay, and that also depends, and that is because of improved services or access to neonatal intensive care in those situations. I've seen 24, 26 weekers live here in Africa, but the numbers are not high enough for us to drop our age of viability. Okay, so what are the types of miscarriages a woman can have? When a woman does come into the clinic, oh doctor, I'm about 8 weeks or 10 weeks and I'm bleeding per vagina, I have some little lower abdominal pain. The next thing is that, okay, we would want to do a scan, check the cervix, and then do a scan to check whether the baby is still there or not, whether the fetal heart is still there or not. And we check the cervix to see if the cervix, which is the doorway to the womb, is opened or not. And that will decide for us the type of miscarriage that woman who has presented is having. So sometimes we'll tell the woman, oh madam, I can see that your cervix, even though you are bleeding, I can see that your cervix is closed, and I did a scan. I can still see the sac. I can still see the baby inside the sac. And not only that, I can still see the fetal heart. In that sort of situation, we will say the woman has what? A threatened miscarriage. And I always explain it as that, somebody threatening to slap you, but he has not actually slapped you, he only threatened. So, and there are ways to manage such a woman with threatened miscarriage. So the other type of miscarriage a woman can have is inevitable. Inevitable miscarriage means that it's almost certain that the pregnancy is going to come down. Like she comes in bleeding per vagina. I do a speculum examination by putting that device into the vagina to expose the cervix. So when I'm looking at the cervix and I see that the cervix is opened already. And when I did a scan, I see that the sac of the baby, instead of it being round, is a bit collapsed. In such a situation, even though the sac has not come out, I'm telling them, oh, madam, I am thinking that this is an inevitable abortion because the cervix, which is the doorway to the womb, is partly opened or fully open. It's partly open. So I will tell her, madam, this is an inevitable abortion. Another type of abortion, the third, is that inevitable abortion, when she has come, may have progressed towards an incomplete abortion, whereby the cervix is opened and some of the sac or some of the products of conception, like tissues. That's why sometimes when the woman comes, when the patient comes and that I am bleeding per vagina, we want to ask, is it free-flowing blood? Or there are some little particles, tissue-like, inside of that free-flowing blood. If she says there are some tissue-like, then we start to think that, oh, some products of conception may be losing itself, may be coming out from the cervix. So that will tell me that this is possibly an incomplete miscarriage. So that is the third type of miscarriage, the incomplete miscarriage. And with such a woman, when you do a scan, without seeing the sac is fully collapsed, or you may not even see the sac at all, you may just see some tissue-like materials within the womb. And so, oh, this is an incomplete miscarriage. Another type of miscarriage is what? A complete miscarriage, whereby both the sac, all the tissue have come out of the womb. And the woman, by that time, the bleeding must have reduced significantly. It means that she has totally lost the pregnancy and all the tissue have come out. There is another type of miscarriage a woman could have, whereby she's not bleeding. She has not come to you bleeding. She's not even having abdominal pain. Okay? Because those are the two most common presentation of why a woman will come to the hospital in a miscarriage situation. She's bleeding and she's having lower abdominal pain. But in this type of miscarriage, the woman may not actually be bleeding or very minimal spotting. And that is called a missed, M-I-S-S-E, the missed abortion or miscarriage. Means that the fetus has stopped growing maybe at 7 weeks or 8 weeks or 9 weeks, but the body has not expelled the baby. Because what happens in the miscarriage? Please, somebody's audio is on, please. We will appreciate it to be off. Okay. That is Matron's phone, please. Matron, your audio is on. Please. Thank you so much. Okay, so back to what I was saying. In missed abortion, the woman, as I was saying, in miscarriage, once a baby has stopped to grow, the womb and the body senses this. And we always attempt to expel such products since it has stopped growing. So it's going to want to push it out. So that's why the woman will come with bleeding and with lower abdominal pain. And let me say this. I always tell women when they come in with miscarriage and they are not happy, it's understandable. It's a sorry situation. But at the same time, I tell them to be a blessing in disguise. That is because the body is designed to sustain a fit individual. So when an embryo is formed from the joining of the egg and the sperm, and it is not well formed, the body will realize that this is not perfect enough. And obviously, we want to expel such a situation. And in actual fact, 1 in 5 women, that is about 20% of women have miscarriages. 20%, that's a significant number. May actually be more than that, but that is the evidence we do have as at present, as much as 1 in 5 women. Okay, as I was saying, back to the missed abortion, the body refuses to expel the baby. So when maybe the woman has come, oh, I've been in my period for 2 months now, okay, I want to register for antenatal. I say, okay, part of this, let's do a scan. We find out that, oh, the sac is there, the baby is there, but I cannot see the fetal heart pulsating. So I said, madam, you are not bleeding, no pain. I know, no, doctor, I'm not having any of such. In such a situation, we say that this is a missed abortion. Another type of miscarriage could be what we call a septic abortion. In other words, an infected miscarriage, meaning that maybe the woman had an incomplete miscarriage. And we talked about incomplete, meaning that there are still some particles remaining. And the woman never came into the hospital thinking that everything has come out. And you know, when you leave a dead tissue in a place, just like you buy meat in the market, you don't put it into the freezer and you keep it near your room, what will happen will be that it starts to smell, it starts to become infected. So that will also happen in such a situation with septic miscarriage, which could be a life-threatening situation. So do please, anytime one starts to bleed, please see us in the hospital, whereby we can do the right things for you. Okay? And the last one is recurrent abortion. Recurrent abortion. I've had cases of having to marry women for recurrent abortion. And when we talk about recurrent abortion, we mean that a woman has lost 3 first trimester pregnancies back to back for the same husband in the first trimester. Okay, so we'll try to look at the possible causes of recurrent miscarriages, and we have been able to help 1 or 2 of the women who have come our way with a history of recurrent miscarriages, because there are some clear-cut reasons why a woman may continue to have some recurrent miscarriages. So we'll quickly look at what are the causes for why women will miscarry. What are some of the causes why women will miscarry? Number 1 and the most common cause is what? Chromosomal abnormality. You know, when the egg and the sperm met, they just did not form well, or the chromosomes were not properly aligned. The body senses it and ultimately wants to expel such right away, such that a fit individual is what is allowed to thrive. And we also have something called antiphospholipid syndrome. It looks like a big word, but it's actually the most treatable cause of recurrent miscarriages. Fibroids could also cause miscarriages, okay, depending on the position, the size, the location of the fibroids, it may cause miscarriages. And seeing your doctor will help you try to elucidate why that will happen. Some people also have some clotting disorders, okay, with just like systemic lupus erythematosus, that could make their blood to clot unduly. Such women are readily manageable in conjunction with the rheumatologist, okay, and we have been having some good results in cases like that. Infections, vaginal infections, any infections that cause fever can also cause miscarriages. Malaria can cause miscarriages, okay. Unmanaged, poorly managed diabetes can cause miscarriages. Poorly managed thyroid diseases can cause miscarriages. Trauma can cause miscarriages. Okay, even trauma of bad roads can also cause miscarriages. Okay, a weak cervix can cause recurrent miscarriages when the cervix is weak. And when we get to the area of cerclage, that is where we are going to talk about that weak cervix. Okay, and as you know, women with miscarriages, the 2 most common ways of presenting: bleeding, lower abdominal pain. So if you don't have any of this, you obviously want to see your doctor so that he can categorize your miscarriages. With a threatened miscarriage, the outcome is good, the prognosis is good if properly managed. Okay, And in many situations, whether it was an IVF pregnancy or a spontaneous conception, whether a single baby, twin baby, or triplet baby, okay, we have been able to save the situation. And it's important to know that twin gestation, multiple gestation increases the risk for miscarriages. That is because with twin and triplet, the risk of chromosomal congenital anomaly is high. And the body, as I told you, we always want to expel what it sees as not properly aligned. Okay. And when women present with miscarriages, what do we do for them? Once we have decided what type of miscarriage it is threatened, obviously we want to admit and give the necessary medications and treatments to try as much as possible to sustain that. And if what is causing that is due to infection, maybe urinary tract infection, malaria, any infection from anywhere, we also want to give antibiotics to take care of that, because if those things are still not taken care of, it keeps irritating the uterus, and the uterus will want to expel what is inside. However, if unfortunately it's an incomplete miscarriage, then obviously we want to offer the woman the opportunity to complete it. That is because if we do not complete evacuating that uterus, it may proceed to a septic abortion, also called an infected abortion, which would do what? Impair her ability later to get pregnant. Because it can do what? Block the tubes. The infection could block the tubes, if not catered for. So it's important that you come to the hospital and not stay at home so that you can be covered with antibiotics as necessary and your womb evacuated, which could be with some drugs or a traditional D&C or that most people know about. Okay, so those are some of the ways we do manage miscarriage. Very quickly, we'll look at cervical cerclage. We've had many reasons to put in a cervical cerclage. What is a cerclage? We know the neck of the womb. If you look at a balloon, or blowing a balloon, the womb is like that balloon. Okay, why that place that we blow to make that balloon big is the cervix. Okay, sometimes for whatever reason, the cervix could be weak. Okay, the cervix could be weak. It may be just congenitally weak. That's the way the woman came into the world, congenitally weak. Okay, and in such a woman, how will we identify that Madam, this cervix is weak? It's because that she has carried the pregnancy till about 20 weeks, 24 weeks. One day she was just in the toilet thinking that she wanted Hello, I am sorry. I don't know what's happened to the connection. For the days Nigeria, sometimes these connections may suddenly get missing. But please, can you hear me? Can anybody respond if you can hear me and I'm back?
Yes,
Yes,
sir.
Can hear you.
Thanks. So I think I started with cerclage, right? Where I went into the cerclage topic. Okay, as I said, cerclage is I described a balloon and the neck of the balloon like the cervix, and which can be weak. And I was trying to talk about the possible reasons why that neck of the balloon or that cervix is weak. I said it may be congenitally weak. The woman has come with that into the world. And other reasons could be that the woman has had some multiple dilatation D&Cs, and instead of removing the products from the womb, whoever was aggressive and damaged part of the cervix, so that could also make the cervix weak. Or A woman has had a procedure on that cervix. Maybe the woman had pre-cancerous lesions of the cervix, and maybe they had to cut part of the cervix to remove that lesion. So that obviously will make that cervix weak. So those reasons may make a cervix weak and unable to support a pregnancy as the pregnancy is growing big. And that's why we will see that a woman who have a weak cervix, the first pregnancy they may lose may be about 26 weeks. By the time they are pregnant again, they may now lose the pregnancy at 24 weeks or 23 weeks. The next one may be at 20 weeks. It's classical because the gestational age at which she's losing the babies keep reducing. That is the classical presentation of a weak cervix. Okay, and the truth of the matter is that do I want to wait for 3 losses before I say, madam, you have a weak cervix, so let us go and put a cerclage around the cervix. That looks a little bit not too palatable for our women. And that's why sometimes after a first loss, and depending on how that loss happened, most gynecologists will want to do what? Make a diagnosis without having to wait for the classical 3 losses. Okay? They want to make a diagnosis of the fact that the woman has a weak cervix and that there's a need to put a cerclage around that cervix. And what is this classical presentation? Is that the woman all of a sudden feels as if she wants to defecate. She goes into the toilet, and while she's trying to bear down, the fetus falls into the loo. That looks very classical, and that is because of the painless dilatation of the cervix, the painless opening up of the cervix. We all know that if the cervix is going to open in normal labor, it is painful, obviously. It is painful. But in weak cervix, the cervix just opens very easily and painlessly. Or also the woman may just suddenly break her water at 26 weeks, followed by expulsion of the product of conception. So in such a situation, I would obviously think also of weak cervix. I won't say, madam, go and get pregnant again. I want to see what will happen in the next pregnancy. So in such a situation, I may overdiagnose a weak cervix, and I lose nothing from overdiagnosing because I wouldn't want to put the woman through a psychological situation whereby she loses another pregnancy at 23 weeks, knowing that she has seen a specialist following the loss of that 26-week pregnancy. Okay, so those are some reasons why we want to put in a cerclage for some women. And when we are going to put in the cerclage, electively, we want to put in the cerclage after the first trimester. That is because majority of miscarriages will happen in the first trimester due to chromosomal abnormalities and other causes. So if a woman has passed that first trimester, so by 13 weeks or so, we want to put in a cervical cerclage. Most commonly, we have 2 methods, 2 very known methods of cervical cerclage going through the vagina, which is the McDonald and the Shirodka. Okay, do not be too encumbered with such names. So we can go into the vagina and tie the neck of the womb. That's what we just want to do. It's like bracing your door so that nobody pushes that door, because as the pregnancy grows bigger and bigger, there's a lot of pressure on that cervix. Okay, so if that cervix is weak, it won't be able to carry the baby. So we want to brace the door by putting a rope around the neck of the cervix, around the neck of that balloon, so that it carries the baby till when we want it to carry the baby. So, but there are some situations whereby, following examination of that cervix, we see that the cervix is too short for us to go in per vagina and put a cerclage around the cervix. In such a situation, what do we want to do? We will want to offer the woman a trans-abdominal approach. or laparoscopic approach, whereby it is from the abdomen I want to go in and tie the neck of the womb, because that cervix from below is too short, so we want to go from above. I have a patient like that. She has done 2 cerclages. Is it 2 or 3 now? I can't remember. But I know she has done 2, maybe 3, per vaginal, and all failed her. And 1 was done by a professor also. It failed her, possibly because the cervix was too short. So this time around, she was referred for a laparoscopy, that is from the abdomen. She had her womb, the neck of the womb tied, and she has her baby today. Okay, so and that is an option. Okay, the one we do and when we go per abdomen to do that, just like for that woman, obviously we do not remove the cerclage. It's there permanently until she finishes all the babies she wants to give birth to. But when we go per vaginal, we want to remove that cerclage. Okay, so when do we remove the cerclage after we have had it done? Cerclage has its own complications, maybe infection, injury to surrounding structures, obviously, some bleeding could happen. However, if you look at the benefit of doing the cerclage, it obviously is going to outweigh the risk of losing another baby. So one needs to balance both discussions and have that discussion with the client before she signs the consent form and we go in for the procedure. So when do we want to remove the cerclage? For women who we plan to have a vaginal delivery for, by 37 weeks, we want to remove the cerclage. That is because the woman has to contract before you remove that cerclage. Because that cerclage is very, very tough. And it's not distensible. It's not like elastic. It will hardly give way. So what will give way will be that cervix, which is soft. Okay, so we want to remove it before she falls into labor, because if not removed, the woman can tear that cervix, can lead to severe bleeding. Okay, so that is cervical cerclage. Very quickly, we'll go to placenta previa. Yeah, okay, placenta previa. Okay, what is placenta previa? Still remember the description of the balloon I was talking about. Okay. Placenta previa is a situation whereby that bottom of the balloon, the placenta is staying there. And I use a description like, you have a whole room like this, and the doorway is where the placenta wants to go and stay. That is called placenta previa because it is staying in the lower segments of the womb. And we don't like it to stay there for obvious reasons. How can somebody be blocking the way from which the baby is able to come out from? Not good at all. Secondly, we know that the doorway has very, very thin muscles compared to the other part of the balloon. Okay, top of the balloon, sides of the balloon, thick muscles. But that bottom part of the balloon where you want to blow that balloon, the muscles are thin. So when the baby even delivers, you need the tough muscles to do what? To block those bleeding vessels. But that will not happen in placenta previa because that lower part of the womb is very thin and the woman will just be bleeding. Okay, so what are some of the reasons why some women will have normal placentas sighted and some women will have low-lying placenta? Well, you could use low-lying placenta and placenta previa interchangeably, but for the clinician, we want to use low-lying placenta before the age of viability, that is before 28 weeks. Why we want to see placenta previa after the age of viability. But for everybody, well, placenta previa, low-lying placenta, both are fine, okay? At least it's the information that is more important. The placenta is close to the doorway, okay? So what are some of the reasons why a woman may have a low-lying placenta? She may have had a previous history of placenta previa, so that may predispose her to another low-lying placenta. She may also have had other surgeries of the womb, like fibroid surgery, previous cesarean section, There are risk factors for what? Placenta previa. What of multiple pregnancy? Twins, triplets, 4 babies. They run the risk of having placenta previa. And why? It's because the placenta will be so large to supply the 3 or 2 babies or 4 babies. So even though the placenta is on the sides of the balloon, some of them may just spill over into that lower part of the balloon. And we end up with placenta previa. So those are some causes of placenta previa. And there are different types of that low-lying placenta. We have the minor and the major. The minor may be offered vaginal delivery, depending on what the gynecologist, the obstetrician is seeing. However, when it's major, clear cut, no discussion, cesarean section. Okay, so for minor, you and your obstetrician they go through, okay, what are the pros or what are the cons of having a vaginal delivery in such a situation? And how will women present? Sometimes when I see women with some threatened miscarriages, okay, and eventually they have low-lying placenta, there is a link because the warning bleeding in the early days of the pregnancy may be a pointer to the fact that may there, mark the word may there be a placenta previa. Okay, so the most common presentation once again for placenta previa is what? Painless vaginal bleeding. Okay, the woman will come with pain, so won't have any abdominal pain. The baby will still be fine. Okay, depending on the volume of blood loss in any case. Okay, and once we have made our diagnosis, okay, are this a low-lying placenta? How many weeks is this woman? Or so weeks. Then we start to determine if we can salvage the baby or not, or we need to intervene right away and bring out the baby. Such a woman obviously want to benefit from a lot of bed rest because this is an internal bleeding. Okay, so there's no way you want to take the wound, want to pack it with gauze, you want to put iodine. Obviously, it's not external. So a lot of bed rest and some medications is going to help the woman in trying to allow nature to heal that placenta that has shifted. And we also should know that with low-lying placenta, by the time we are doing a normal scan of about 20-22 weeks, and we are seeing low-lying placenta, we usually will want to tell the woman that, Madam, don't be too worried, because once you tell them placenta is low-lying, oh, they're so worried. Go meet their pastors, go meet their mothers, and say, oh, they get so emotionally disturbed. I tell them, do not worry. I want to scan you again at about 34 weeks because we know that as the womb grows bigger and bigger and bigger, the placenta is carried along with that growth. So a low-lying placenta today will not be the same tomorrow. And that is why, as I told you, for we as obstetricians, we want to use the word low-lying before 28 weeks. And after 28 weeks, we want to say placenta previa because we know that a low-lying today will not be low-lying tomorrow. So I will stop there, okay, and entertain questions. Okay, so please, if you do have questions from these 3 topics, clarifications, okay, any input at all, either from this topic or from previous topics, we are more than happy to oblige you, okay, and answer those questions. So please go ahead. Thank you.
Okay, good morning, doctor.
Yeah, good morning, madam.
Okay, thank you very much for the lectures. I have a question, but it doesn't have anything to do with what was discussed today. It was a personal experience I had. So before now, each time I go to the hospital, I'm always given a test strip to urinate on. Yes, and each time I urinate on it, it doesn't have any color. It just comes out colorless. But last week when I went in, I'm actually 32 weeks gone.
Okay.
I used test strips and it was showing green. So before now, it doesn't have color, but when I used it was showing green. So I showed the nurse and she said I should discard it. So when I went in to see the guy, I told him about it, and then he checked the system and said nothing was logged in as abnormality. So I don't know. You know, something you go every day and you see a different thing. All of a sudden, you're seeing something different. It just got me worried, and don't know if you can help me clarify.
Okay, thank you, madam. Well, that strip they gave you contains 2 small dots. I think they are yellow, if I'm correct, right? Possibly. Okay.
Yes, sir.
It's meant to check for glucose, which is also called sugar, and protein in your urine. Okay. If it's glucose, we obviously want to go further and think that is there any situation of diabetes in this woman, so we want to do further tests. If it's protein, we want to think of any kidney affectation, and in pregnancy, any association with your blood pressure in a situation called preeclampsia. Okay. And I always tell women that when they give you that strip, it's coming from a container. You don't want to hold it in air for too long. You want to go as quickly as possible to go. If you're not ready to urinate, please hold on with the strip. I'm not yet ready to urinate. Now, I see some women holding it for the next couple of minutes before they are present, 15 minutes or so. Okay, you don't want to do that. And secondly, when you go to urinate, always use the midstream urine. What I mean is that at the beginning of urination, that is not when you want to put the strip, because some things around the vulva, the first urine may just pour some of those things on that and may give that thing a color. Okay, so you want to use a mist to mean that the urine is coming out, then you want to put it in the middle of the urinary stream. Okay, and that's what we want. Okay, so yes, I agree with you that if it changes color, you want to take note of that. But obviously, there are grades to those coloring. Okay, it starts with trace, 1+, 2+, 3 pluses or so. Okay, usually when you come back and they look at the strip, they have the color code in their mind, or they look at the container once again to appreciate how deep that green is. Okay, if it's a trace, maybe that's what your gynae saw, trace, and it's a trace urine. And I would have asked women, did you use it at the beginning of the strip and some things fell on it, or in the middle of the strip? So trace usually will not be that significant for us to start to raise full value about it, even as much as 1+, except some other parameters are there. So if your gynae tells you, maybe looks at your blood pressure, okay, looks at leg swelling and says that, okay, you have nothing to worry about. Actually, you have nothing to worry about. Okay, but if that strip has come back as 2 pluses, or that glucose you have come back as 2 pluses, obviously it starts to raise alarm bells and you want to investigate further. So they must have looked at the intensity of that color for them to have told you there was nothing to worry about. But it's a good observation. Okay.
All right, thank you, sir.
Yeah.
Good morning, doctor.
Yeah, good morning. Let me get, somebody sent a message.
Okay.
Let me since you are talking, let me listen to you, then I'll read the message out.
Okay. Doctor, I just wanted to clarify this part. I don't know if you already spoke about it, about Razor's mother, negative mother, having threatened miscarriage. I don't know, maybe I didn't join in earlier or something. No. Yeah, because I'm a Razor's negative mother, and then I bled at 12 weeks. So I don't know if there is any future information I need to know or something. But
did you get program, madam? Did you get program? Did you get program?
Yes, I was given program.
Beautiful, you had program. So no, we cannot cover all the treatment modalities because that is for the clinician. I don't want to make this topic too medical for our minds. Okay, sir. So with threatened miscarriage or any type of miscarriage, either in the first trimester or not, we want to give our women program because we want to protect future babies. Okay, there's a topic on its own on Razor's negative mothers. So maybe it may come or it has already come. We can check through the Zoom link and see. Okay, but it is good you had Rogan, and we will always offer that to women who are resource negative. Okay, so let me go through that question. Chat. Okay, good morning, doc. I am 16 weeks gone and first pregnancy and the first pregnancy. My last visit, I was given calcium and one red tab. The doc said I should stop my folic acid, but I have been worried that I am not to continue my pregnant care. Okay, most people assume that red capsule given to them is just iron alone. So in their mind, they think that it's just iron and calcium they are getting from Mother and Child Hospital, but that is not so. Okay, that red capsule contains iron, folic acid, B complexes, and vitamin C. Okay, we don't want to be giving you those small ones because it will be difficult to swallow, and you need to take it 3 times a day. So that looks like hard work for our women, because obviously nausea and vomiting of pregnancy is a problem for women. So, madam, you do not need folic acid. And I will always say, if you want to take pregnant care, be my guest. If you like to spend money, be my guest. But what I'm giving you is sufficient to meet your prenatal needs, okay? And which is fine by me, okay? And that's why we give you that ranferon. So it's not just iron that is in it. You have those 4 necessary things, okay, to make it complete for your consumption.
Doctor, good morning.
Yeah, good morning.
Yes, please. I'm 21 weeks gone, and this week I started to have heartburns.
Oh,
I have had Gaviscon tablets in the house, and I take say one, or there's a day I had it so bad that I had to take like 2 tablets that day, chewable tablets, but I didn't get the go ahead from the doctor to take it. So that's what I'm asking. But I got relieved after taking the tablets. It happens basically at night. Yesterday, I watched what I ate. I ate very little at night and I did not have it. But I want to know if it's okay to take it whenever I have the heartburn.
Okay, ma. You see, heartburn is not alien to pregnancy, and the reasons are obviously clear-cut. One, that developing womb, it keeps pushing from below and pushing, because your stomach is just below your chest region. Normally, when we eat, our stomach expands downward, but now we have the womb growing from downward and coming up into our chest region. So it's going to push the stomach content back into our chest. And you know, the stomach is naturally acidic. So as it pushes those things back into our chest, what happens? We will have heartburn. And not just that, for the pregnant women, because of the hormones of pregnancy, especially progesterone, it does not allow food to move quickly along our guts. So food will stay longer, a little bit longer in our stomach, okay? So it doesn't move. So those 2 reasons increases the risk for heartburn for us. Okay, and why you may experience it more at night is that at night, obviously, you want to lie down. But during the day, you are standing up, you are sitting up. So as you lie down, gravity may push those stomach contents back into your chest, your esophagus, which is the tube that connects your mouth to your stomach. So taking of antacids, whether in tablet form, liquid form, is fine. You can do that. I also even encourage my clients to put their antacid into the fridge, because cold water or the cold antacid may do what? May soothe that discomfort you are feeling at that time. So there's nothing wrong with you taking that. You may also want to put a liquid antacid into the fridge and take it when needed. Patients can also take cold milk, cold yogurt to try to help the heartburn that comes with pregnancy. And you see, you are 21 weeks. It's important to know that as the womb grows to 26, 28, the push against that your stomach will be more. So there is more risk, there is more heartburn ahead, okay? So, but nothing to worry about. You will just manage it as it comes, okay? And I always advocate that pregnant women should eat little meals many times a day, because you now know that food does not pass easily through those pipelines, okay? So you want to eat little meals many times a day, because if you eat a bulky meal at once, obviously it won't move on time. More acid will be produced to work on that food. Some may go back into your chest region, causing you heartburn. So little meals many times a day will help us. So let me read the question here. So I hope that
Thank
is
you,
okay,
doctor.
madam.
That's fine, sir. Thank you, sir.
Okay, ma'am. Okay, doctor, please, I'm a first timer, and last I came to just I was 30 weeks gone. Until now, the gender of my baby cannot be determined. Is it normal or is something possibly wrong? Okay, I would like to say this without fear of favor that the gender of a baby is a social discussion. It does not in any way interfere with the clinical management of a baby. If it's a boy or a girl, we are not in any way going to manage that woman any differently. Okay? So, and you know, as I always say that if we are checking for the sex of a baby, when I'm doing my anomaly scan, my first aim or the aim of any sonographer is to check that the baby is fine, properly formed. The sex will obviously come secondary. If the baby's legs are open, obviously you will see what is in between. But if the baby's legs are closed, obviously it will be difficult. Okay, but I will not make that my overriding aim in doing a scan. Okay, and so the possible reason why they have not found it is that the person looking at it may be unsure because maybe the baby's legs are closed as at that time. Okay, so you may want to repeat it, but if you are repeating, if you are doing it, it's important to know that it does not affect the clinical or obstetric situation of that pregnancy. Okay, and many people may go and buy some gender neutral colors so that they won't even be having the headache of I must know what the gender of the baby is. We do know what the gender is, will that detract from whether I love the baby more or I love the baby less? Okay, so there's apparently nothing wrong if they can't pick the gender and they may not want to confabulate and be telling you that, oh, it's a boy, oh, it's a girl. So they want to be sure before telling you. So basically nothing wrong with your baby. Okay. Any other question? Okay, I'm a first timer. I'm 23 weeks gone. I observed my legs are a bit swollen with slight pains. I observed this yesterday. Leg swelling in pregnancy could be normal. Actually, majority of the time it is normal. That is because when I see a woman complains of leg swelling, that is both leg swelling, I want to look at her blood pressure. I want to look at her urinalysis to see whether there is no protein. And when I say protein, I mean significant protein. Trace and 1+ of protein may not be significant. Okay, so I want to check all those parameters. And if they are fine, I want to once again counsel her that leg swelling in pregnancy could be normal. That is because the womb is serving as a wedge, preventing blood and fluid flow from the lower part of our body to the heart region. So it's wedging somewhere in the middle there. So it's preventing adequate adequate flow of fluid. So that has caused such swelling. And knowing that in women, our blood volume has increased by 40% by dilution. Okay, so that increased 40%, obviously we have a place to stay. So some fluid may leak into our lower limbs. There are sometimes even your ring finger, you can see that it's swollen also. You have to go and remove your ring and keep because it can't enter. And some women also complain of pain around the wrist joint. And I've told them the carpal tunnel syndrome of pregnancy. Carpal tunnel syndrome is because of the fluid that has gone under your wrist is compressing on a nerve there. Okay, that is causing you pain on the wrist, whereby sometimes you won't be able to hold a pen at all. Okay, so those are so leg swelling in pregnancy is most times normal, but obviously you want to ask your doctor so that he can give you this information and also check your blood pressure, which you can also check when you do your blood pressure. Oh, madam, is my blood pressure fine from nurse? Okay, my urine, I hope it's fine. If there is fine, oh, then you're happy. And though the leg swelling will also be uncomfortable because the shoes we were wearing yesterday, you can't wear them today. So ways to help you know that it is fluid that has caused that is that you can elevate your legs when lying down, put them on a pillow to allow some fluid to do what? To drain backward. But you know that during the day, it will reaccumulate because we are standing and walking during the day and water will always find its level. Okay. So any other question?
Yes, doctor. I have two questions, but it's not related to today's topic anyway.
Go ahead.
I'm 24 weeks gone. For so few weeks, you've spoken about swollen legs, but in my own case, my mom made an observation yesterday when I complained to her that I've not been having frequent urine as I should. I noticed before I urinate frequently. Even at times during the night, I wake up 2-3 times. But lately, I don't wake up at night to urinate. And during the day, maybe twice maximum in the office before I go home. So I can practically count how many times I urinate in a day. So she was like, probably that's what's causing the flu, that I should complain. I was supposed to come in today, but I remember there won't be a gynae at the office today, at the clinic today, because she said I ought to take a particular medication that will make me to have free flow of urine. She has advised I increase my liquid intake, which I have, but I'm not seeing my body is retaining the water. Yesterday I took 3 plastic bottles of water consecutively, and I urinate just little. That's
but what liters were they?
No, like I took it at a stretch. Just
okay. Is that all?
Frequent urination and see how well with the water come out of my body.
Okay.
But the urine wasn't as much. Yes.
Okay. Once our kidney is functioning well,
I have less.
Okay, that is fine, man. So let me answer the question. Okay. Yeah.
Can I complete? Okay. Just I still have another question that it's really.
Your network is breaking. Hello.
But me, affected to 3 days back, I noticed my hands and my leg were itching me seriously. And after having a close look at it, I discovered there are rashes all over it. My fingers, my finger lines, my toes, and it has now spread to my hand down to my wrist and to my ankle. But to be honest, for a couple of nights I've not had any sound sleep. I stay awake to itch myself all through the night. Even in the day.
Some rashes.
Yes.
Okay. If you're having those rashes, madam, obviously maybe they are intensely pruritic itching you. I would advise you come in and see the gynae so that they can take a look at those rashes for you, characterize them, make a decision. Okay. And however, is it heat related? You want to check other parts of the body whether you have those rashes there?
I don't have in other parts of the body.
Have you changed your soap, your bedding?
Yeah, that was an observation that I noticed. Maybe I changed anything. No, I didn't change my cream. I'm not reacting. I've tried figuring out if I'm reacting to something. But nothing new. My meal, I didn't have any strange thing.
Please do come in. Do come in and see us, because we also do know that if uric acid builds up in our body, and if we are not urinating well, and there's build up of uric acid, that may also cause us some itching. So please do come in, okay? This case is individualized, so please do come in so that you can have a kidney function test done, and you are reviewed by timing, okay?
All right, sir.
You can determine if actually there is any, you are actually not making adequate urine as you say. Okay, you may obviously be required to be admitted so that you can take a 24-hour urine analysis and check what volume you are giving us in 24 hours, because we always want a certain volume. Okay, and we can analyze that urine for you and also take blood. Please do come in with this complaint. Sort them out.
All right, sir. Thank you very much.
welcome. There's a question here. Okay. Does anesthetist turn off epidural when it is time to push? No, we do not turn off the epidural when it is time to push, because the time to push also is not only during the opening of the cervix phase that the woman has pain. Even when she is trying to push, she will have pain. So we do not turn off the epidural. Okay. I would like to know the measures. This one has disappeared. I would like to know the measures that can take to prevent tears during pregnancy. Please, can we turn off our? Let me mute everybody. Mute up. Somebody said, what can I do to prevent tears during pregnancy? Sorry, during, I guess that is the second stage of labor, where they will take you to the pushing stage and tell you to push out the baby. Okay. We try to prevent unnecessary tears by doing what? Guiding the head of the baby. So that is at the level of the midwife or the doctor who is taking your delivery. He wants to ensure that he guides the head of the baby adequately, and as and when necessary, gives you an episiotomy, that is a planned cut to prevent an unnecessary tear. Okay, but a proper guiding of the head will help you. That is because for a first timer, the vagina and the perineum is very, very tight. Very, very tight. And if you allow the baby to just come out like that, the woman can tear straight into the bum. And God forbid, she will now be having fecal incontinence, whereby poo will be coming out, she will be defecating, she'll be wearing pampers, okay? Flatus should be gassing without control. So you want to prevent unnecessary tears, okay? So that question is your acupuncture, who is your gynae or your midwife that handles that situation, okay? To prevent unnecessary tears for you. Is it okay to take cough syrup and drug for flu? I'm presently coughing and also I can't just take any medication. Well, you want to take what is prescribed for you by your doctor, obviously, because your doctor will know what is safe for you, because there will be some cough syrups that we may not want you to take. So you want to take the approved cough syrup by your doctor. So please, and drug for flu, well, depends on the drug. So that will be at the behest of your doctor. So let your doctor write a prescription for you. I usually do not just talk about prescriptions on air so that people not say, let me go and buy that. But you may not know the reason or reasons why I have chosen this particular medication for this particular client. Okay, so it's important to see your gynae, because patients can take cough syrup and flu drugs, but you want to see your doctor so that you are sure that this one is going to do what work for me. Okay. Okay. It's 12 o'clock now. I think we have exceeded by 4 minutes. Okay. So we would like to appreciate those of us who have joined and benefited. As I always say, if you have questions, just jot them down on your phone or somewhere. When you come to the Antenatal clinic, we can always have quick 5 minutes of recap or the explanation of any of those gray areas you may have had. So thank you so much, everybody. God bless you all. We love you. Mother and child loves you. Goodbye.
Thank you, doctor.
You're welcome.